Welcome to This Week in Cardiology. This week we're covering 10 notable papers spanning heart failure, from what actually drives the benefit of our drugs to how outcomes have changed over a decade. Plus, anticoagulation and thrombotic risk in two very different populations, and a cluster of papers on imaging, risk staging, and the aging frail patient in front of you. Let's dive in. Start with heart failure with mildly reduced or preserved ejection fraction, where a meta-analysis in Heart tackles a question that has nagged at us since the sodium-glucose cotransporter 2 inhibitor trials. Are we treating heart failure, or are we just treating blood pressure? Polling 18 randomized trials and just over 39,000 patients, pharmacological blood pressure lowering was associated with a roughly 14% reduction in the composite of cardiovascular death and heart failure hospitalization, and about a 17% reduction in heart failure hospitalizations alone. But the important signal is in the heterogeneity. Benefit was confined to specific drug classes: sodium-glucose cotransporter 2 inhibitors, mineralocorticoid receptor antagonists, the angiotensin receptor neprilysin inhibitor, and glucagon-like peptide 1 receptor agonists, and not seen with the other antihypertensive classes. Crucially, meta-regression found no relationship between how much blood pressure fell and how much outcomes improved. The author's conclusion is that blood pressure lowering alone cannot explain the benefits of our established heart failure therapies. Practically, that means don't choose an agent in heart failure with preserved ejection fraction because it lowers blood pressure, and don't assume a generic antihypertensive will substitute for a disease-modifying one. Alongside that, the European Heart Journal published a temporal comparison of two large Japanese registries, JROADHF from 2013 and JROADHF Next from 2019 to 2021, with propensity matching yielding about 3,000 patients in each era. Guideline recommended pharmacotherapy rose modestly, beta blockers from 75 to 81%, mineralocorticoid receptor antagonists from 54 to 61%. But the striking changes were in the non-pharmacological domain. Cardiac rehabilitation went from 44 to 89%, and nutritional guidance from 3% to 56%. One-year mortality fell by about 27%, and heart failure readmission by about 52%. Renin-angiotensin system inhibitors, beta blockers, and nutritional guidance were each independently associated with better survival, while the dominant predictor of reduced readmission was simply the cohort effect. That is, broader changes in post-discharge care and health system organization rather than any single drug. That's a useful counterweight to a drug-centric view of heart failure quality improvement. And if you want to intervene even earlier, the Journal of the American Heart Association reports on nearly 3,000 RIC participants with stage B, or pre-heart failure, defined by echocardiographic or biomarker criteria, mean age 76. Over a median of 8.4 years, there were 338 incident heart failure events. Compared with those reporting little or no fatigue, high exertional fatigue roughly double the risk of developing clinical heart failure, and those with both high general and high exertional fatigue had over twice the risk. General fatigue alone did not reach significance. All fatigue categories predicted incident heart failure with preserved ejection fraction, but none predicted the reduced ejection fraction phenotype. Fatigue also tracked with markedly worse physical and mental quality of life before any clinical diagnosis. The message is that a simple question about exertional fatigue in a patient with structural heart disease but no symptoms carries real prognostic weight, and that quality of life is already impaired in the pre-heart failure state. Turning to anticoagulation, Annals of Internal Medicine published a target trial emulation using Taiwan's population-wide claims data, addressing a genuine guideline gap. Direct oral anticoagulants versus Warfarin in atrial fibrillation with mitral stenosis. Compared with Warfarin, direct oral anticoagulants were associated with a higher one-year risk of ischemic stroke, a risk ratio of about 1.22, with an absolute risk difference of roughly 5 percentage points, and a similar excess for composite stroke. Rivaroxaban specifically showed increased ischemic stroke risk over both short and long-term follow-up. There was a lower risk of myocardial infarction with direct oral anticoagulants, and no difference in bleeding or all-cause mortality. This is observational, sample size was limited, mitral stenosis severity was not characterized, and there were no international normalized ratio data, so this is not a randomized answer. But it aligns with existing guidance that rheumatic mitral stenosis remains Warfarin territory, and it should make you pause before reflexively switching such a patient to a direct oral anticoagulant for convenience. On the venous side, the European Heart Journal reports a Danish nationwide cohort of nearly 64,000 women with endometriosis matched 4:1 to over 255,000 controls across nearly 5 decades. Venous thromboembolism incidence was about 2.2 versus 1.5 per 1,000 person years, and after adjustment for comorbidities and hormonal contraception, endometriosis was associated with roughly a 50% higher long-term risk, with similar magnitude for deep venous thrombosis and pulmonary embolism separately. The absolute risk remains low, so this is not a case for prophylaxis, but it is a reason to treat endometriosis as a modest chronic inflammatory contributor to thrombotic risk, relevant when counseling about estrogen-containing contraception and when weighing pretest probability in a young woman presenting with dyspnea or calf pain. 3 papers this week refine how we use tests and devices. In the Journal of the American Heart Association, a Lausanne cohort of 503 episodes of suspected infective endocarditis, half of which were confirmed, examined whether repeating transthoracic echocardiography earns its place. A second transthoracic study, performed at a median of 8 days, found new vegetations in 7% and new paravalvular complications in 3%, raising sensitivity for vegetations from 47 to 57%. But within a real multimodality strategy, repeat transthoracic echocardiography reclassified possible to definite endocarditis in only about 1% of cases. So when suspicion stays high, the yield lies in transoesophageal echocardiography, cardiac computed tomography, or nuclear imaging, not in another transthoracic study. From the same journal, a Mayo Clinic cohort of 441 patients with newly diagnosed transthyretin amyloid cardiomyopathy, 85% on tafamidis, asked whether staging systems built in the pre-treatment era still discriminate. They do. Both the National Amyloidosis Center system and a modified Mayo system using high-sensitivity troponin T-separated 3-year survival from roughly 92% in stage 1 down to the mid-40s in stage 3, and an extended 4-stage model using an N-terminal pro-B-type natriuretic peptide threshold above 10,000 identified a stage 4 group with about 34% 3-year survival. Useful for counseling and for triaging who needs urgent escalation. And a single-center observational study, also in the Journal of the American Heart Association, measured serial haptoglobin in 91 patients with cardiogenic shock supported by intra-aortic balloon pump, or Impella CP. Low haptoglobin indicating subclinical hemolysis occurred in 67% with Impella versus 31% with the balloon pump, with divergence beginning as early as 12 hours. Impella use, concomitant veno-arterial extracorporeal membrane oxygenation, and lower mean arterial pressure were independent predictors. Overt clinical hemolysis was uncommon and similar between devices. Small and non-randomized, but it supports serial haptoglobin monitoring as an early signal in microaxial pump patients. Finally, 2 publications address the patient, our trials underrepresent. A 2026 American College of Cardiology scientific statement in the Journal of the American College of Cardiology argues that cardiovascular disease, cognitive impairment and frailty in older adults should be viewed as shared manifestations of biological aging, vascular dysfunction, chronic inflammation, sarcopenia, and recommends routine assessment, targeting common modifiable risk factors, structured exercise and nutrition, and limiting polypharmacy, while candidly acknowledging that the evidence base for these common sense complementing that, Annals of Internal Medicine offers a grand rounds debate between a general internist and a cardiologist over an 80-year-old man with multiple cardiopulmonary comorbidities facing extensive skin cancer surgery, framed by the 2024 American Heart Association and American College of Cardiology perioperative guideline, and centered on stratifying risk without overtesting the low-risk patient. If you only have time for one paper this week, make it the target trial emulation of direct oral anticoagulants versus Warfarin in atrial fibrillation with mitral stenosis in Annals of Internal Medicine. It addresses a decision many of us face without randomized data, and it argues against a switch that is very tempting to make. Here are the key takeaways from this week in cardiology. In heart failure with mildly reduced or preserved ejection fraction, benefit tracks with drug class, not with millimeters of mercury. Choose disease-modifying agents, not just antihypertensives. Registry data show real-world heart failure outcomes have improved substantially, with the readmission gains driven largely by rehabilitation, nutrition, and post-discharge systems rather than drugs alone. Ask patients with stage B heart failure about exertional fatigue, it roughly doubles the risk of progressing to clinical heart failure, especially the preserved ejection fraction phenotype. In atrial fibrillation with mitral stenosis, warfarin still looks safer for stroke prevention than a direct oral anticoagulant. When endocarditis suspicion persists, go to advanced imaging rather than a third transthoracic echocardiogram. And endometriosis carries a modest but real long-term excess venous thromboembolism risk worth factoring into contraceptive counseling and diagnostic suspicion. That's your roundup for this week in cardiology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And if you have a paper you have been meaning to read, upload the PDF or paste any link at audioscholar.cc. We will turn it into audio like this one in any of 31 languages. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.